pressure is going to be high. It's a new doctor. If the blood pressure goes down, let's say the next reading is 130/75, probably the 130/75 better represents what's going on in your body, because the blood pressure is just a snapshot in time. Let's say the doctor measures it twice. It's still 150/80. Are you going to start treating right away? No. What should be done next is, well, what is your overall risk? So now we think you have high blood pressure, although this is just your first visit to the doctor's office. So, we'll check that again at a follow-up visit or something. But what are the other risk factors? Do you smoke? Are you overweight? And obesity, which is a nasty term in our society, it has all kinds of connotations, but somebody who's 5'5" and weighs more than 180 pounds is categorized as obese. It doesn't mean, all it means is that you have a higher risk of having problems with your heart and blood vessels. Smoking, obesity, lab tests, you're going to want to check the cholesterol, you're going to want to check the sugar. So all of these other processes, and there's more, if those are in existence also, the doctor's going to be more critical about that blood pressure. So if you have none of those and you just have a blood pressure of 150/80, the doctor, one, is going to want to see you back or have you take your blood pressure as an outpatient, and two, would probably be more likely to try non-pharmacologic ways of getting the blood pressure down. So not start with pills, but start with either lowering the blood pressure, lowering your weight, changing your diet, things like that, which are going to help your overall health. I can go on, but I don't know if you wanted to step in.
One thing actually that you mentioned is what's sometimes referred to as a white coat syndrome.
Right.
I walk in the doctor's office, I'm a little nervous about it, and my blood pressure kind of goes up. Mm-hmm. And that's usually the top number with the systolic. It's different if it's the bottom number, and we'll get into that in just a little bit. But once that passes, obviously if you see that pressure kind of drop and you relax, and I didn't run in from the car either, and I'm not nervous, I'm relaxed, then that's sort of more of your baseline type of blood pressure. I do think that exercise is very important for lowering blood pressure. Obviously, weight loss is very important, especially with the American diet, where you do eat a lot of, meats and fats and
salt. Yep.
Obviously, salt on a lot of things. Absolutely, that is very important. And I'd like to go a little bit into that in just a moment. We'll be right back. We also want to speak about some of the medications that are used to treat blood pressure, because there are many out there. We'll touch upon that as well. We'll be right back with Dr. Michael Rudolph and to speak about high blood pressure. Stay tuned. Welcome back to Healthcare from the Hill. We are discussing high blood pressure or hypertension, the silent killer when it gets very worse. We're speaking with Dr. Michael Rudolph, and I want to go back to the scenario of a patient or individual just walking into the office, for instance, and diagnosed with high blood pressure. Now let's say, Dr. Rudolph, if that same individual walks into the office, doesn't have really any symptoms, but the blood pressure is still consistently 150 on 80 or 160 on 80. What do you do then?
Right. So let's say you've gone through all the things. Probably you've tried diet. Well, first the next week you get another blood pressure reading. Let's pretend it's still exactly the same, 150 over 80. You go to the Stop and Shop. It's 148 over 78, sometimes 155 over 82, depending on how your day worked. But you're convinced, after you look over all the labs and everything, this blood pressure needs to be treated with medication because other things haven't worked, and we're sure that it's real high blood pressure, not white coat. Then you usually start, the first thing to do is to recommend to the patient what we think should be done. Some patients have extreme fears of medication based on what they've heard. There are side effects to every medication. And sometimes before you can even start to treat somebody with medication, you have to address the fear. What is the likelihood that I'm going to, for instance, lose sexual function from a medication? You know, if they've heard from their friend, hey, I couldn't perform after I got put on the blood pressure medication, well, that's going to stick in their head. If I tell a patient, well, it's probably 2% of people, and if that happens to you, we can take you off the medication, they're probably going to be more likely to be able to give that medication a try. When the blood pressure is what we call stage 1 hypertension, and I'll focus on the upper number just because that's where the majority of high blood pressure is. Stage 1 is anything between 140 and 160. You usually start with one medication. Whenever physicians and patients who are being treated for blood pressure start on medication, you should know that it's likely that you're going to need more than one medication. Unfortunately, blood pressure as people age often gets more difficult to treat. So even if you were on one medication to start with, you may end up on 2, sometimes 3, but let's not make you too worried about the medications. The recommendations from the national committees are to start with a diuretic, which is a water pill, which lowers the amount of salt in your body and has been shown to decrease events in the long run. Back to the slides, what we're trying to do is decrease strokes, heart attacks, heart failure, which means the pump is not strong enough to get the fluid out of your lungs and other parts of the body, peripheral vascular disease where the arteries are damaged, among other things, and kidney disease. So again, if I'm trying to convince a patient that it's in their best interest, I know from studies, if you take people at age 40 with a couple of other risk factors, let's say they smoke and they're overweight, common in the US, if I treat 100 patients, if I treat 10 patients for 10 years, I'm going to save a life. Now, do I know if it's patient number 1 or patient number 6? I don't know. But as a doctor, that convinces me that I'm doing the right thing. As a patient, most people you say, well, you can lower your odds by 10% of dying in the next 10 years. You know, it sounds very serious, but most people would say, okay, I think it's worth a try.
I would say it's worth a try.
Yeah,
absolutely.
I think that that's the American values. If you ask a 90-year-old, is it worth taking a medication to lower your risk of death, they may say, I've had enough. So it really depends on patient preference and, you know, where they are in their life.
Well, if we actually go back to the medication, so sort of a first drug to use is more of a diuretic or kind of a water pill to lower the salt. There are other type of medications out there, calcium channel blockers, angiotensin inhibitors. How do you sort of maneuver from there? Where do you go on to use other medications?
Right. So sometimes it depends on cost constraints. In other words, some people without health insurance cannot afford certain types of blood pressure medications. So as most people know, there are $5 generics at most pharmacies, so I might start with that. Other people, it may depend on their race. So black folks, definitely, I should say African American patients, should use calcium channel blockers more than ACE inhibitors.
So in that population, that medication worked better
Right.
for those
Right.
subset of people.
And then sometimes you look at the other illnesses surrounding or conditions surrounding. So in a patient with diabetes, actually the first medication you go to is something called an ACE inhibitor because it has beneficial effects for the kidneys, and kidney failure or progressive kidney disease is much more common in diabetics. So it depends on a lot of different factors, some of them pure medical factors, some of them social factors. And the other thing is patient factors. Gee, I heard, you know, my mom needed a pacemaker because her beta blocker dose was too high. And I could try to explain, but if they're fixed on, geez, I'm worried about beta blockers, then I'm probably going to try another medication because they're more likely to have faith, not worry about that medication.
So if also one medication is not working, there are other ways they can approach the high blood pressure to treat it effectively.
Right. Usually, I found it rare that a medication just doesn't work. If it's just not working, it's usually because the dose isn't high enough, or possibly the patient is forgetting to take it, or there's some issue. But you might get not a great response, just a 5-point drop from 150 to 145. That's meaningful. That will help your heart and preventing strokes, but you want it better, so often you add a second medication. And fortunately, drug companies have a lot of combination medications so that you still, the ideal, I believe, for patient compliance, remembering to take it, being able to afford it, everything, is 1 pill a day. So if you have 2 medications in 1 pill, people are going to be a lot more likely to take it.
So compliance is better, obviously.
Exactly, yeah.
And I just want to touch on the upper compared to lower number. Now, let's say if the patient comes in and their lower number, the diastolic pressure is 110.
Right. So diastolic is elevated lower number, elevated diastolic is less common than elevated systolic, but has equal concerns. So anything above 90 diastolic is of concern, and that needs to be treated. You know, if you think back about the pump, you know, you have the pump and then the time in the blood vessels where the pump's filling back up. Turns out that 1/3 of the time blood is flowing through your blood vessels, it's the pump or the systolic, and the other 2/3 is the diastolic. So
Or the resting blood pressure.
Yeah, exactly. So the diastolic is very important also. Just kind of back to malignant hypertension, the absolute number for blood pressure is, although we use it to treat 100 people, these are our guidelines for 100 people, somebody who usually has a blood pressure of 170 and you're really trying hard to get it low, who suddenly comes in with a blood pressure of 200, you say, 200, wow, that's a big number. Turns out that somebody who usually has a blood pressure of 120, and now they're 170, you gained 50 points. So that person, even though the absolute number is lower, the effect on their organs is probably greater because of the change in the sudden, or maybe not so sudden change. Actually, sudden change is even more stress on the body. If the blood pressure in an hour goes from 120 to 170, the body hasn't had time to compensate. So a lot of treating blood pressure is not just a number, although when you're in the office and people are otherwise feeling fine, that's what we have to go by. But when the numbers get high, when you make decisions in the hospital, out of the hospital, depends on how quickly it changed and if the patient's having symptoms.
So overall, it's important when you see the patient, if they have symptoms or no symptoms, if their blood pressure stays consistently high, their age, activity, and of course to try non-medication type of treatment,
Right.
and then move over to the medication.
Right.
Well, thank you very much, Dr.
Certainly.
Rudolph. I appreciate the information.
Yep.
Stay tuned, and we'll close in just a moment.